Welcome to the Project Unity podcast series, where we explore different topics within global healthcare. Education plays a major role in advancing global health, and as such, in our mission to reduce health inequities, we bring on specialists from different backgrounds and fields, like lab researchers or policy experts. Every month, we dive into the narratives of these specialists, leaders, and community members that are engaged in the battle against widespread chronic conditions, such as HIV or diabetes. Our goal is to educate and inspire the community and you to take action. At Project Unity, we're not just discussing public health. We're trying to pave the way for positive change. Whether you're interested in public health, medicine, policy, community service, this podcast should serve as your gateway to find captivating stories and ignite transformation. In celebration of National Diabetes Awareness Month, we're excited to present a luminary in the field, none other than the remarkable Dr. Ann Peters. As a distinguished endocrinologist at the University of Southern California, she holds the titles of Professor of Medicine at the Keck School of Medicine and Director of the USC Clinical Diabetes Program. Nationally acclaimed for her innovative strategies in diabetes diagnosis and treatment, Dr. Ann Peters. Thank you for gracing us with your insights today. Welcome, everyone, to an enlightening episode of Project Unity. Hello, everybody. My name is Alex Elamine. My position with Project Unity is I am a National Director for Outreach. And just a little bit about Project Unity for people who are tuning in for the first time. We're an organization working on bringing public health awareness and education and taking actionable steps in order to bring medicine and community and health to the people who are underserved and to the people who may be marginalized in medicine. And today we have with us the Honorable Dr. Peters. Dr. Peters has a very impressive track record from what we've seen involved in, the leading research, diabetes prevention and treatment. I've seen many publications from you, Dr. Peters, and a lot of guidelines were contributed to by Dr. Peters on the committee. So we're very grateful to have you on today and to hear more about you, about diabetes prevention and treatment, especially in communities that are underserved or more at risk. That's all for me, and I'd love for you to introduce yourself and hear more about you.
Sure. So I'm a diabetologist, so all I do is take care of people with diabetes. And it's a very long story, but when I was a little girl, like 6 years old, I was in New York City and was sharing a desk with a little boy, and they told me that I had to teach this little boy how to read. And it'd be really easy. But he was from a poor family, and he was Black, and he was often absent because he was sick. And realized then, and I'd already decided to be a doctor, that I didn't know it at the time, but I was saying to myself, it's the social determinants of health that matter here. And
Yes.
I decided I would always work in under-resourced communities and try to provide health care because I thought that health and education were the two keys to success in life. And so I've always done work in under-resourced communities as well as better served communities. And it's been the best thing I could possibly choose to do. And I've been able to be the voice of people who otherwise don't have a voice at the CDC, the FDA, and NIH. It's been a great career, but really it starts from when I was 6 years old and decided I needed to do something.
From that early on, very inspiring 6-year-old. Better than me when I was 6. I was probably still eating crayons. But if I understood correctly, you used to work more in rural areas before moving to Los Angeles. Is that something you can speak on?
Well, I didn't really work in rural areas. I'm from Wisconsin, and that's
Okay.
state. But I did my medical school at the University of Chicago, and then Stanford, and then I moved to Los Angeles because it's the most popular county in the United States and has the most resource people with. So most of my work has been in county and underserved communities in urban areas, but I'm obviously very interested in rural areas. I'm sitting here currently because I think that both urban and rural communities need a lot of help.
Yeah, definitely agree. And just to dive a little bit more into some of the research you've done specifically for underserved communities. I have in front of me a few of the papers you've published specifically for patient-centered models of healthcare delivery for low-income patients for type 1 diabetes. I see one for specialized technology education problems for underserved populations and long-term outcomes for Latino patients and diabetes disease management. Um, I would love to hear a little bit more about what has been effective in serving these communities and what the biggest differences are going from community to community, or do you get the sense that marginalized communities generally face the same sort of risks in diabetes treatment?
Well, first of all, the risks are much, much greater in marginalized communities because they don't have, healthy food. They have food insecurity. They're not living in places they can go for a walk. There's, freeway traffic and all sorts of things. But I've learned many things. One is that I know nothing because I know how to take care of diabetes, but what I don't know how to do is to take care of your diabetes. And if you live in a
Mhm.
different community, the first thing I have to do is get to know the community. And so when I went into this community, I went into South and East LA, which are both first communities. I just spent 2 years getting to know communities. And then they kept saying, why should we do research with you? Researchers come in, they get information from us and they leave us no better. I said, I promise I'll stay. And so not only have I stayed, we embedded our research group in a health center. So we work within the community and
Mhm.
everything we do is informed by the community. And, I could tell you 1,000 ways in which research is different there. And, I just think this cookie cutter approach of, gee, we're a pharmaceutical company and we need to get more under resourced people to look like we're doing a good thing, but they still have the same protocol. My patients can't follow that protocol. They can't miss work on a schedule because if they miss work, they can't feed their family. They can't do
Yes.
things. But if you give me the resources and the time, educators, I think it happens. So I've learned a lot, and I think people are more aware, but I still don't think that they really understand what it's like. And since I spent half my time in the community, I'm blessed to be able to understand it. And again, every time I go to clinic, I'm shocked at the challenges these people face. I'm humbled
Mhm.
because I could help them and they're letting me help them, but it's all about doing it with them, not for them.
Of course. And just from what I know, background knowledge about specifically the challenge these community face. I mean, you already mentioned food insecurity and the quality of food that is available for, say, lower income populations. A lot of high fatty foods and foods loaded with carbohydrate. Those are the cheapest things available, and it's very easy to see how that contributes to diabetes difficulties. But something that I don't often hear talked about as well is the non-diet component of diabetes. So, looking at both of these factors, what are the most um, frequent issues in getting treatment and aid to people? Is it that, like you mentioned, it's difficult for them to follow protocol? Is it difficult to get them to access proper foods and nutrition and dietitians? Um, is it just a lack of awareness?
Well, it's all about lack of access, right? So when I got a patient with diabetes in my resource community, they have many complications that could have been prevented. But when I give them to a dietitian, they can lose
Mhm.
weight, exercise just like anyone else. Or I get access to medications. And again, it's all about having a hand to hold. So I get people, all of my staff works and lives in the community. So they trust the people who are giving medications. But we've done amazing things. But listen, so the first thing the community wanted was to have us help them bring in farmers market. And we were able to have it work with food stamps, give them cooking lessons. Needed a lot to do that. And that 20 years
Wow.
later, the farm markets are still going. And I'm not the only person who did this, but they asked us to help them, and we helped them. And they did. We helped them. And I feel like, again, it's about listening, but it's all about access, but access to whatever it is, plus an educator, plus somebody to help you. Because these people
Mhm.
have literacy and numeracy skills that maybe we take for granted. So I've
Yeah.
always given them, whatever, a continuous glucose monitor plus an educator to help them with it. And if you do that, they do just as well as anybody else. There's no reason they can't do well, but they have to have somebody there to help. And I think it's because the level that they're starting at is all much lower in terms of the health literacy that you don't realize how that they need to do to get base point.
Hmm. And it's, it's very interesting. It's very, very admirable that it's a very community centered approach. But what are what are the factors that cause these specific communities to experience greater degrees? I mean, in Los Angeles, seems like low income populations are especially at risk. But why is it that you and the organizations you work with need to step in and take over on education and treatment and be the person there they rely on? So, what are some of the policy changes, advocacy efforts, or legislation, anything that, from your perspective as a doctor, could improve these people and allow you to reach even more populations?
Well, the thing that we've done, and again, I credit a lot of people working on this, is the Department of Health Services of the County of Los Angeles has been very willing to take input from. So we have basically
Hmm.
a committee that gives advice, and they decided that quality and the kind of care we gave was as important as the cost. And so they're willing to give high quality health care to people. And things like the Affordable Health Care Act actually really help expand Medi-Cal.
Hmm.
It's called Medicaid. So we have more people covered. And then I've been up to Sacramento, lobbied and, got certain things built passed that helped cover people. So there's a tremendous amount of advocacy that's involved. But these people often didn't start with having health care, and they live in communities that were redlined, and they don't have good internet access, and they're working, 2 or 3 really low-paying jobs. These people don't have any job security. They don't have any job safety, and it's a really hard world. There's a lot of crime. There's a lot of, people becoming homeless. There's things that in my world, don't realize, but their lives are so hard. And then, there's 10 people living in a 2-bedroom apartment, and there's not enough bandwidth for people to all be on the. There's just so many things going on that make it
Hmm.
hard for them to prioritize healthcare. So
Yeah.
you have to integrate, but the communities have to embrace it. The lives of these people are just really problematic. And you really want to do everything you can to make it better. And that's why advocacy matters so much. I mean, we need to make a healthier built environment, make it so they can't, they're not at risk of getting shot when they walk outside. There's a lot of things that need to go into this. But I've
Yeah.
looked from the medical perspective, and I have been so lucky to be in Los Angeles County and in the state of California. We've been able to access and get the kind of care people need. I don't know what state where that didn't happen, but in California, fight to get people what they need works.
Hmm. That's I'm learning a lot from that even. So I mean, it seems like hopefully if I were to be a future physician, that's where I would start, then finding people in advocacy and policy that are willing to listen and get a medical professional's perspective on who has been in the community and is integrated in the community. That's what I'm taking away from that. And something that interests me is you're right that it's very difficult for people doing 2 3 jobs, low paying, going about their days, to be able to manage their symptoms and treatment and follow up with treatment. So, have you had any experiences with any technologies, or is the advancement of technology alleviating those issues? I remember reading some of your research on oral insulin. Was it? Is that something that's more accessible and affordable? Are there other technologies which makes it easier for these people in communities as they move about in their lives to manage diabetes?
Well, I could give you the cynical answer, but I'll give you the real answer is that technology creates a further gap. There's this digital divide between the haves and the have nots. And any technology is more expensive. And unless you can get education, training, and access, you're not going to use it. But my research recently has been to just give technology to plus education. And I've showed tremendous benefit. I've shown that people where they've not been able to do better, given the right technology, are doing amazingly better. And the County of Los Angeles and the state of California and Medi-Cal is actually paying for it. So I've been able to show that, again, it takes the time and the education piece, but people are much aided by technology. But giving anybody technology doesn't fix anything, right? You got to couple it with the other parts. But it's been really to see, because at first I got all discouraged, and I go to clinic and I would see all these people who needed technology but didn't have access, and I head down on the desk and feel like crying. But now I can actually get it. So again, it's about the advocacy that's allowed us to get the tools we need, the ability to implement. So I think that you need to fight for that. And I think the problem with a lot of people is they're in one system or another. So you're either in a more fee-for-service world or a medical group, or you're in an under-resourced hospital system. And I'm in both worlds. So I work part of the time in a very well-resourced clinic, people who have, resources. And then I work with these under-resourced people. And I can say there shouldn't be a divide. There shouldn't be a gap. And so I'm going to take what I learned from the wealthier population and make sure that the under-resourced people gets it. So I'm kind of the thorn in the side of these, LA County, but it's a gap. And if you don't do the right thing, people go blind. They get amputations. It's horrible. Cancer.
Yeah.
So
Yeah.
I know, but I think that to me, it's having the perspective of both worlds, because if you know no other world than the one you're in, you don't have perspective on what's possible. And I just feel really lucky that I've been able to work in both.
Mhm. Of course. And I mean, you mentioned education being a very important factor in doing all this. When you say education, what do you mean by that? Are you organizing programs and initiatives yourself, through you teaching, or are you partnering with schools and dispersing material, or is it through hospitals? What does education look like? Where is it most impactful?
Oh, I think it's most impactful at the level of the patient and the device. So if you have somebody and you want them to be on a continuous monitor, either teach them one-on-one with an educator or have a group class. And, they need the fun stuff. This isn't like, a lot of these people don't have internet connections and they can't really do stuff on Zoom. But I do that a lot in the West. But I think that, using things like community colleges and all sorts of training people to help. I believe in the whole mentor system, that you can, learn from your peers who are more successful or have been exposed to these tools. But, in my world, I mostly have just had individual educators train people. And I've trained more educators, but every time I do that, the county health system, any health system, pulls them all away. And they say, oh, we need more primary care people. We'll take away your staff. I'm like, So that's, and I'm not joking. It's really hard to get what you need to do a specific disease. Diabetes is so common. It's so common,
Yes.
and we need the resources. And it's not doctors. I mean, you need doctors to champion it. And when people have looked at what makes these programs work, it's a physician champion fight to get the resources, make sure they're available.
Well, I think something else that prompts me to think of is, have you seen any sort of feedback loop in these communities by any chance? So, I mean, you train a lot of people to work with them one-on-one and educate others. And, sometimes they're pulled away to take care of other things. So have you been able to get people within the communities you're working with involved? So not just educated on their own diabetes, but are there any initiatives to teach them to take up and relay the education and care to others? Because, a great way to get a community to be self-sustaining and self-benefiting is to get them involved. So,
Well, there have been lots of initiatives to do lay health workers or promotores or health coaches. But it's interesting, because when we ask our population, and we've tried all, like the Robert Wood Johnson grant, the patients actually said, why should I ask my neighbor to help me take care of my diabetes? I want to ask a doctor. And so it was interesting. I think the thing about all of this is that it's a palette of choices. Do you want a mentor? Do you want a coach? Do you want an educator? Do you want a doctor? I mean, I don't care how people want to learn. I just want to have the ability to provide whatever they need it. I mean, I'm not so sure that I wouldn't want my neighbor to tell me how to manage any disease. You know what I mean? I'm not just joking. It's like, I actually want a healthcare team. And so I think that people, you have to listen to what they want. I can come up with 1,000 good ideas, but they aren't my, their ideas. You again have to listen to what people want.
Hmm. No, that's very understandable. And you know, have people? I mean, if that's the case, then has there been a neighbor that has said, you know what, I want to join the healthcare team? Have you seen any instances of that where
Had a lot.
you come to communities and they join you?
Yeah. We've had a lot of people that we've trained who are interns who've joined the staff. All sorts of things. I think that there's been a tremendous amount of external benefit this way, but I would want, if it were an ideal world, to train even more people. I've trained many interns along the way, and they've really gone out and done good things. But I'm not training hundreds of people. I can only train so many. I'm only one person. So I think there needs to be a greater effort to train, allied healthcare professionals to do this, and then there has to be payment for it. There has to be a job at the end of it. So you got to, but that's, I think, increasing. There's more of an awareness of the benefit of, having someone specialize in this who's not necessarily, specific, obviously not a physician or even not a nurse practitioner, although nurse practitioners are incredibly good. But all sorts of different people in the healthcare system can do these things.
Hmm. And in terms of remaining involved in the communities, I'm interested to hear about what sort of challenges or even opportunities came up after the COVID-19 pandemic. I mean, you mentioned a lot of these people don't necessarily have Wi-Fi or computers or access to Zoom. So I don't know if telehealth was an available option. I'd love to hear more about how you remained in the communities and remained safe.
Well, let's see. We could never stop going into clinic because there wasn't enough in telehealth. We tried to do telephone,
Uh-huh.
which we did, but I'm not so sure so wildly effectively. I got COVID in March of 2020. I was one of the first cases of patient care. I was
I'm sorry to hear.
in the very beginning, and then I got really bad long COVID. But then you know what? You just don't care. So, I mean, we all went to work. What are you going to do? I mean, it was
Yeah.
awful. Our patients died. It was just awful. And actually, both my parents died before the vaccine came out. Everyone died. It was awful. But we were just there. And I think that one of the things that made the community even more connected is we got charitable donors to give us free devices pandemic. So I actually most expanded my capacity to help people because of this. So it was actually oddly a good thing. But
Mhm.
you can't stop as a doctor. I almost got completely burnt out, to be fair, really hard. But we did it, and we got through the other side, and we got everybody vaccinated. We got vaccinated. It was okay in the end.
What what were the things that like pulled you through that burnout? I mean, I'm sure there were moments where it's just like, with everything you described to me, being in these communities, what are the things that really push you through to keep working with them and seeking the next community and planting the seeds there? That's a
And,
tough question. I'm sorry. If you're comfortable answering, of
but
course.
you'll understand this. Any day that you're in clinic and one person smiles because you help them makes the next day worth it. And I had so many calls and so many sick people and so many scared people. And I was there when other people's doctors weren't. I'm just the kind of person there for people. I felt like I helped people. And I think if you feel that, it keeps you going. And it goes back to why I'm a doctor, because I feel like it was a calling. I don't think I chose it. I think it chose me. And so I just feel like the I'm telling you, it was so hard because I've never been so busy. But you get through it. And then I thought at the end of it, maybe I should just quit, but because I don't have to keep working if I don't want to. But I decided to do it because, what do I value in myself? It's the ability to heal people, help them. And I'm telling you, I tell my fellows, I say, if there's just one person today in clinic that you've made a difference for, that's one person. And then maybe
Yes.
people. And you know what I mean? That's just all you have to do. But it's you just have to feel that way. The other thing is that I've never particularly worked for money, which makes it different. I don't have to worry about whatever. I mean, not that I'm independently wealthy, I'm not, but I've worked in settings that weren't pressuring me to make sure, met some quota for income. And I've had an academic salary. I make nothing, but that's fine, and so it was more like I could give of myself rather than worrying about finances or something. It was actually really a nice, odd thing to go through. And I started, by the way, at a general when HIV was just. So I took care of people on the HIV ward at San Francisco General way back. So I've been through a lot of this in my lifetime. And I think that's what being a doctor, just do it because you have that skill.
Mm-hmm. Mm-hmm. No, I completely agree. And I just want to double check on time. I want to be respectful of your time. So about how much longer do you think, I know we told you like 20, 30 minutes, so I want to do my best to keep on time.
And my husband will be starving to death.
Okay, we don't want that to happen. So just a couple more questions. One more is, how do you bridge a personal divide with patients, or community members you may interact with? Do you ever feel like, just with life experience or life stories or different situations that not necessarily that it's difficult to understand, but I just recall on some experiences I had in some volunteer teams, and on one hand, I think about what better things could have been done to help the communities and what my presence there really was for. But on the other hand, on a personal level, I'm glad I really learned that sometimes I just, I come from a very, thankfully, more, how do I phrase it? Like, it took a while for me to understand how to really connect with these people when we come from such fundamentally different backstories. Like, you can't really make small talk or about the shows that came out or the phones. Some of these people, as you mentioned, are really going through um, um, difficult lives and difficult struggles. And how do you feel like just by being there for the patient, that's enough to bridge that divide, or how do you go about that?
I think you just listen and care. I mean, most physicians don't spend much time listening. And you also need to know that patients want to please you as a doctor and will often not tell you the truth. So I often have another provider, a dietitian. The best person in my whole clinic is a social worker because they'll often share the social worker that they won't tell with me so that I see it as a team effort. So I'm good at listening and I try to understand, and I'm not sure I can always empathize, but I can sympathize. But the social worker giving me some background, or one of my team members will say, she's she's garage at home because she can't sit inside, and they feed her whatever leftovers they have, and she can't help food. You have to say what's really going on, but you can't confront them because people are proud, and I don't want to make anybody feel less than me. I want to make them
Yes.
understand that we're all human. So I think it's that human connection that makes it work. But it's an empathy, and I'm not a role model because everybody has my cell phone. I mean, I'm just looking, and I just got texted by a patient, so I'm called 24/7, 365 days a year. So don't try to be me, but being me is be there, and I think that it's being present more than
Mm-hmm.
anything that matters. So that in fact, I go back to clinic every week. The fact that I was there for the pandemic, I was present and I listened, and that's what
Mm-hmm.
builds trust. You got to build trust.
That's very insightful to hear. And the final question, just to wrap it off, and I'll let you go have dinner. I'm assuming, a lot of us on Project Unity and potential listeners are students or early on in their academic careers or aspiring physicians. What advice would you give for us and how we can really contribute, how we can put in our 2 cents and reach out and bridge to these communities and provide before being physicians? What can we do?
Well, I think there are a lot of volunteer opportunities. You just have to get in with a group that is well respected in the community. So I did, even when I was a doctor, I worked with the vet, which is a big clinic here, and did work. So I think it helps to volunteer with that already has those connections with the community. And I think
Mm-hmm.
you have to just be really humble because you're going to be a big, and again, it's about listening and it's about, understanding, but, being very keen to learn. As you get older, I think understanding that even though you may be a dog in a big, big medical group, whatever, that you still have to have a voice for people that don't have a voice, and try to talk. I've always volunteered my whole life. I've never not volunteered, no matter. And I've been a busy mom. I've been a single mom. I've done all this stuff, and I always did volunteer work. And there's something really special about being a volunteer, and I think that we forget. And the other thing I think is that understanding a community as much as you can from within. And I helped raise a Black child from a very poor community, and I went there every other weekend and took care of her. I just learned so much from all these wonderful experiences. But, volunteering, I'm telling you, it seems like it takes a lot out of you, but it gives so much back.
No, I completely agree. Just being there and hearing people's stories. And, a lot of the times, especially near Harvard campus, we have a few youth shelters, homeless shelters, and just going there and we cook up a meal. I went there with my roommate once and we made a bunch of crepes and just kind of sat around and talked to everybody. And it's a really enriching experience to be able to remind yourself that listening is such a powerful tool and just being present is such a powerful tool. Those are all the questions I had, Dr. Peters. I really, really, from the bottom of my heart, thank you so much for being here with us today and taking the time. I'm hoping that everyone listens to this really, it takes to heart what you mentioned about just being compassionate and present and giving your full to these communities, because a lot of the times, if there's no one else willing to do that, even just listening, a lending ear and putting that to mind is all the world of difference. That's all. We're at time. If you have anything else to add, by all means. But other than that, thank you so much. And hopefully I look forward to speaking with you again.
Of course. I'm here if you need me.